Thank you all so much for having me, and also to obviously being very interested into the topic of my talk, which is exactly the sexuality, fertility, and body image in AYA cancer patients and survivors. So in the next 30 minutes, I would like to go through the following content. So we'll start with showing you why preserving fertility, by ticking this box, it will not ensure a psychosexual well-being ever after. And then I would like to take you on a metaphoric journey and showing you why body image and psychosexual well-being is not luxury, but essential for the quality of life in our survivors. And then finally, to introduce you or give you a little overview of the project that I started in 2021. So first of all, I do not have any conflict of interest. So I guess that this sheet you know very well. So I think we can all be proud that we managed to increase the survival rate of our patients to 80% within the last 30 years, which is leading to a rate of 1 out of 530 young adults in their reproductive age groups, which means between 20 and 39 years old, is a survivor of childhood cancer. But as we all know, these new therapeutic strategies also come with side effects, notably gonadotoxicity. So which means there is a problem of fertility. And what we know, especially from the adult setting already, is that it is an extremely important topic, the fertility on the quality of life in the survivors. And we have more and more data also in the young adults and adolescent groups. So which means that 80% of our survivors want to have their own biological children. There is a decrease in quality of life in case of fertility issues. And I think this statement is very, very important. And for me, it was really impressive. It is that infertility is perceived as fatal as the cancer diagnosis itself. So what are we doing about it? What we know is, for sure, you also are aware of the possibility in most of the cases to preserve fertility. So we know that there nowadays, the fertility preservation has become a standard of care before gonadotoxic treatments, especially in adults. And now I think it is more and more also in the awareness in the pediatric setting that there should be a counseling to preserve fertility before the therapy starts. And this for sure also because we have more and more techniques that we can offer also for pre-pubertal boys and girls. So, but still, it is still only 5% of all cancer patients in the age group below 20 will be really referred. I mean, these are older data from 2013, and we are doing slightly better, but still the focus is still more on the adult setting. But well, I think we are doing better. I think the awareness is there. I think the possibilities are there, but what's then? So the idea is to preserve fertility is to increase the quality of life in the end. But what we know is that there is only a very few numbers of cancer survivors who will actually come back and use their frozen gametes, namely sperm, oocytes, ovarian tissue. And especially in the very young age group, of course, it's difficult to know the exact numbers because they are simply too young to really come back. But still, I mean, we are talking about an utilization rate in sperm of 10%, even lower in oocytes, and we know it's approximately 6% only in ovarian tissue. So why is that? Of course, it's difficult to assess, especially when you have the young adult groups or the young survivors. They are moving houses, so it's difficult for sure also to get all the follow-up data. And in the best case scenario, they just get pregnant on their own. They do not need them anymore. In the worst case, for sure, there is a recurrence of the disease or even death of the patient, or just simply decision against having a family, or there's a lack of a partner. So what we know is that especially the AYAs, they experience difficulties in building romantic relationships and are more often single, socially isolated, and suffer from sexual dysfunction and body image issues compared to their peers. So when I was looking into the body image, I was thinking, so it's so difficult to really know what exactly is the body image. And it's not just the picture that we see of ourselves when we look in the mirror. It is more that our body image is more how we feel inside our body. So it's kind of body and mind, they are inseparable. It's kind of yin and yang. And it's more when we look at this picture of my grit, it is what we see as a surface. What we see of the others is also just the surface, but this is just half of the story, right? So what is important is what is in there. What is in there, how do you really feel? And so what we really ask, and often in the therapeutic setting, is, do you occupy your body? So, and then we're thinking of houses, because what else do we occupy? These are namely houses. And when we now think that we are born as houses, so and there's one side, it's the outside. So the facade is given by nature, if we like it or not. So it might be that we come like this modern version, or perhaps like this tiny little hut with the roof, with the huge roof and little tiny windows, or we are born as this simplistic version, or perhaps we are lucky and we are born as a castle. But luckily also, the tastes are different. Not everybody likes castles. And the other thing is that even if we are lucky, and let's say we are born like this castle, it is not staying the same through our lifespan. So we are exposed to weather and atmospheric conditions. We are getting older and we underlie permanent changes. And to a certain degree, for sure, we can try to fix it and to restore it. But for a very large extent, we just have to live with it. So, but this is not the only story, because we also have our neighbors surrounding us. So it's not only for us if we like it or not, but it's very important, of course, that we want to be liked by others. So we have these neighbors, and everybody would love to have these neighbors standing in front of our house and saying, wow, how great it is. Look at that, how beautiful it is, this beautiful house. And they start taking pictures and saying, wow, it's amazing. And then we are all afraid of having these guys standing there and saying, oh my goodness, what is this? But what they all have in common, they also think that how great it must be to live in this house. Oh, how miserable. But this is completely different story. Because if they would then look through the window, it might be that the huge castle is completely empty and cold inside. So because this is a different story. So we all do not come fully furnished. We are coming with some furniture already, but there is an ongoing and huge decoration process in our inside, which is completely independent. And so when we think of course, and everybody can make a castle in the inside, I forget about that, very important point. So from the outside not, but from the inside, we can all make a beautiful castle. And when we now think of all these neighbors, and it comes to stormy weather conditions and to rain, would they just run into the first house that they see? Or would they perhaps first have a glance through the window and then will then make their decisions depending on how cozy it is? Would they not probably prefer to sit in front of this cozy little chimney and warm up in front of the fire rather than just running into this beautiful castle and then ending up in this empty, cold space? So the main task, this is my point, is to make us feel at home in ourselves. And then I was thinking, good, this is about the house and body image, but now how will I bring sexuality into the picture? And then it came to the idea, it is like the Garden Eden. So the Garden Eden is as promising as sexuality. Okay, the Garden Eden, well, the fairy tale says that, yes, there is milk and honey running down the river. They are all fruits and everything is great and beautiful. But this is usually the reality when it comes to sexuality. It's a construction side, especially when we start, right? It is in puberty. You perhaps will see these little butts and you see, okay, wow, is this promising? What will this become? There's a big part of insecurity because we do not really know if this is a promising plant or not. So what we do is that we just have a look over the fence and perhaps we will see that our neighbors had the same plants. And then we see, wow, it's growing slightly. And then in the end, it became this beautiful cherry flower tree. But what would you do if you just discover this creepy plant? Would you also go to your neighbors and say, okay, you know, did you ever see that again? Or are we perhaps also afraid that they might laugh? But the problem is, when we will not ask anybody, nobody will tell us that this is a desert rose that we just have to water. And when we water it, it will become a perhaps even more extraordinary flower than the ordinary and normal cherry flower tree that everybody has. So what I'm about to say is that the size and the plants in our garden might be given by nature, but it is in our hands to make us feel at home in it. And perhaps you're not a garden type at all. And then you say, leave me alone with the garden. I do not want to open it and do not want to improve anything in there. Then it's okay as well. But my point is that you can if you want, right? So, and now when we think we have now our beautiful house, a beautiful garden, everything is perfect, everything is nice. We made it through puberty. We are there. And then cancer comes. And I think cancer is like a tsunami wave. And as I said previously, we are very good that we are not losing the entire house anymore. But the house will not look the same after the tsunami waves and after the cancer therapy. So that's why I think for me, it is absolutely understandable that impaired body image due to physical side effects of cancer treatment is one of the main concerns in AYACs. And of course, it does influence self-esteem and intimate relationship because, of course, before you let somebody into your house, you need to feel good again, that you said, okay, I feel comfortable to show this one around. Even if, and especially when it's not looking perfect, it does not look like it was before. So they might perhaps laugh on me, they might perhaps reject me. So that's why I think it is absolutely understandable that they are also reaching sexual milestones later in life. And they have a higher risk of sexual dysfunction. And over 50% is even ongoing 2 years after diagnosis. And female are twice as likely as male counterparts to have problems. And what I found very interesting is that the problem is not related to poor general health or specific type of cancer treatment. And of course, there's a big fear of being a less valuable dating partner. And they struggle building and engaging in close and romantic relationships. So what are the risk factors? So who is especially at risk to have problems? And again, I think this is also kind of understandable. These are patients that already start with a low self-esteem and a negative body image, those with the highly neurotoxic and gonadotoxic treatment, especially when it comes to ovarian insufficiency, and the peripubertal age. Why is that? Because the pubertal development might be interrupted, namely it is pretty much always interrupted, but sexual feelings and desires, they stay the same. So this development is still ongoing, even if the puberty will just go to a pause. So, but there is, as you all know, when you are in hospital, there's a lack of opportunity to discuss. There's a separation and isolation of peers. They are perceived as children. Perhaps they were starting to get independent from their parents, and suddenly, poof, they are back dependent and be more the child and are perceived as child and not as sexual beings. And of course, it's a lack of intimacy because they are rarely alone. We are just bumping into the room and potentially interrupt them by discovering their body. So even though we know now, and this is also a very, very strong statement, because now it is more and more coming out of studies that adolescent and young adult survivors report that sexual health is one of the most important aspects of quality of life, which is, I think, a very strong statement. And the majority, they report that they would love to have a sexual health counseling. But in contrast to fertility, it is 75 to 95% of survivors, they report that the sexual health aspect is not addressed. And why is that? So the healthcare professionals, what are the barriers? So it is, of course, one is the own embarrassment and fear. perhaps also that they invade and come to, the privacy and come to topics that is perhaps not very comfortable also for the patient. The belief that sexuality is defined solely as sexual function. That's why boys are more often asked, because they can just ask about, do you have an erection or not? The belief that sexuality is not part of the presenting problem, which is namely cancer, and that the clinician's own lack of training in assessing the sexuality. And the cancer patient, of course, as well. So it's their own discomfort, embarrassment. As you all know, it's not easy, even for you probably, to ask a healthcare provider about sexual health issues. And of course, the time constraints during the medical visit, not being asked, hope and helplessness towards an existing solution for the problems. And then on top, it is also barriers to start it, is that they really feel discomfort. So I do not want to feel my provider uncomfortable. Okay, they also feel that it might not be comfortable for the person is in front of them. And also the initiation. So I think that the other one should bring it up, or the healthcare professional should bring it up, and also the validation. I think this is very sad. So I'm worried that there are so many other things that seem more important. It's going to seem like I'm not grateful to be alive because it's such a luxury problem, kind of. So they risk to keep it for themselves and become silent. So when I was for 6 months on a research sabbatical in the Royal Children's Hospital in Melbourne, I did also give a similar talk to an audience, and we wanted to assess a little bit their attitudes towards the body image and sexuality topic in their patients. So they were all professionals working with children, oncological pediatric patients. So it's half of them were clinicians, a third were nurses, and a quarter was nurses, and 25% were others, namely psychologists. So we were asking first, how do you perceive the importance of the body image and sexuality? And it's interesting to see that nearly 100% found it at least important to very important even. And how would you rate the degree of knowledge on this topic that you have? And 70%, it was moderate to non-existing. And then how confident do you feel? And again, they didn't really feel very comfortable and confident, again, in 70%. And then how often are you involved in talking about it? And there was in 55%, they were not involved at all, or very, very rarely. And then who did raise or does raise the topic? And this is in 22%, it was not discussed at all. And here you see again, only 9% it was the patient. And then what are the main obstacles? And I found it very interesting because we just confirmed basically what was already shown previously, that only in 5% there was no obstacle, but the main obstacle was there was a lack of information support and tools. So kind of, what will I do when I start the conversation and my patient will then finally bring up a problem, and then I have no idea what I could tell him because I have a lack of referral. I cannot really give him something, and then I better not start the conversation. And of course, it's also time constraints, one of the main aspects. So, and of course we did ask, but if you would have this guidance and support, would you use it? And I think it's just one who just misclicked it. So it was nearly 100% who said, yes, we would like to have it. So, and also what are the survivors wanting to have? They also want to have a direct communications, so a straight talk. They want that the clinician is initiating it. They want an ongoing conversation because, of course, it is different when you're 14, about to discover your sexuality, and then you, with going older or getting older, then also the focus is different. Perhaps then you will have your first intercourse, and perhaps then you will engage, etc., etc. So they want that they are asked really in an ongoing manner. And they want to have the time alone with the clinicians, so not with the parents especially present, and they want to normalize the conversation. So I think it's important that we should not just ask questions in a way that we think that this particular patient will have a problem. It's more that, like, this is a common problem, and we should, and how is it about you? Do you also did encounter some issues like that? And to individualize. So, and of course, there's no one fits all strategy. It's very easy to say, I know. That's why we started our Just Ask Us project. I will just give you like a very short introduction. So the idea is that the aim is that we want to reduce and prevent fertility and sexuality related distress in the AYC. We want to fill the gap of the unmet needs in the field of sexual health and body image, and offer a non-judgmental space to discuss, and also to lower the barriers and facilitate the discussions for healthcare professionals by being able to give them a flyer, to just refer them to our website and podcast. So we are offering a consultation. We did now build up a platform to ask questions. We have videos where we answer the most important and the most frequently questions. We will now soon launch our first podcast, which will be in English and also in German. And we want also to offer communication workshops to really train people to talk about the topic, and at least, you know, have somebody that these young adults can talk to. So the take-home message now is fertility preservation discussions of great importance in pediatric oncology patients for sure, but body image and psychosexual well-being should equally be integrated in survivorship care. And I think the main aim is that we feel at home in our bodies in order to be able to open our doors to others and maybe to our garden. Thanks a lot. And I do see us more as construction workers. And I think we should defocus on the potential dysfunction, but improving cancer-related knowledge and supporting resources in order to regain a positive image of the body, to strengthen self-esteem, and to rebuild a safe and welcoming home again. So now, thanks a lot for your attention.